Welcome everybody to this introductory workshop webinar on APD workshop. I'm not going to embarrass myself by trying to introduce Dr. Hall. You all know that he has more than 40 years of experience in audiology, particularly in diagnostic audiology, and we all have learned many things from his papers, from his books, and all his work that he's done in his lab. So without further ado, Dr. Hall, to you.
Thank you very much, Jay. And I'll take an opportunity to introduce myself just a little bit further. There's my webcam. It's a little disconcerting to see myself up in the corner there. I'm going to try to shrink it just so I can see most of the slide. That's good. Well, as you can see from this title slide, I'm now teaching at many different universities, which is what I enjoy. My motto is that the world is my classroom in my clinic, and so I enjoy teaching around the world and also helping people develop clinical services and programs around the world. My interest in auditory processing disorder goes back as long as I've been an audiologist. It's a good solid 40 years. Actually, technically, my interest in this topic goes to the years before I was an audiologist. I earned my master's degree in speech pathology at Northwestern University. And if I had time, I would give you a little historical perspective on auditory processing disorders, but to a large extent, they started at Northwestern University. And if you read, excuse me, if you read what James Jerger has written about his interest in auditory processing disorders, it also goes back to Northwestern University. There was a psychologist there, Helmer Michaelbust, who had a clinic at the university for children with language and auditory problems. And Dr. Jerger tells the story about how he went to this clinic the first few days as a student. He was a student. This was the early 1950s, and he was a little concerned and quite confused because most of the kids coming into this clinic had normal hearing sensitivity. They had normal audiograms. Finally, he said to Dr. Michaelbust, I don't think I should be here. I'm an audiologist, but these people have normal hearing. And he was corrected on that by Dr. Michaelbust, who said, well, they may have normal audiograms, but they don't necessarily have normal hearing. And this, I don't know if you can see, here it is. This is a book that Jim Jerger just wrote. It's just kind of on memoirs. A Life in Audiology. I actually got a signed copy of this at the recent American Academy of Audiology convention. I'm referred to as an outstanding student, in case you can't see that. Anyway, Dr. Jerger actually talks about this experience in his book, and he's written about it elsewhere. And so as a student of Dr. Jerger's at Baylor College of Medicine, I immediately assumed this same attitude that many children and adults have auditory processing disorders, even those who might have perfectly normal hearing sensitivity. So I'm not coming to this recently. And throughout my career, I've always made a point of making a distinction between hearing and hearing sensitivity. And if I asked each of you, or any audiologist, what do you do when you're evaluating a patient? You say, well, come on, that's a stupid question. I evaluate their hearing. And then I'll ask, well, what test do you use to do that? Well, I use pure tone audiometry. I use word recognition and quiet. And I would maintain that those really aren't hearing tests. I mean, they're measures of hearing, but they don't evaluate all of what we do when we hear. And so the main focus of this little introductory PowerPoint presentation, and of course a big emphasis in the actual workshop coming up in May, is that we as audiologists need to evaluate hearing. And I'm going to make the point that hearing is auditory processing. Hearing is not an audiogram. Hearing is not hearing sensitivity. Those are very simple hearing tests that don't really tax the auditory system, that we must evaluate the entire auditory system to truly evaluate hearing. Okay, I'm trying to advance the slides. Here we go. So here's the outline for today's pre-workshop webinar. First, I'm going to talk about the rationale for the workshop itself. There are many people in the UK, and I'm sure in the United States and around the world, who would hear about a workshop like this, audiologist, and they would say, well, that's not for me. I don't evaluate auditory processing disorders. I'm just not into that. And I think that is an incorrect attitude, that every audiologist needs to be aware that there are patients with auditory processing disorders, children and adults, and that it's our responsibility to do one of two things. We either need to evaluate them ourselves, or we need to refer them to someone else who can evaluate them. So I'm not saying every audiologist should be an expert in APD. I'm certainly not an expert in certain topics in audiology, certain clinical services I've never provided and never will provide. I've never programmed a cochlear implant. I've very rarely dispensed hearing aids. I've only performed a few balance assessments. So I don't profess to be an expert in those areas, and I'll refer a patient out to a colleague who is an expert instantly. But I know who needs those services. And likewise, I would recommend that every audiologist be able to identify which patients are likely to have auditory processing disorders, and then they can decide, the audiologist can decide, whether to evaluate that patient themselves or to refer the patient to someone who can. So here's a summary of the rationale for this workshop. I've already hinted at the first bullet point here. Auditory processing is hearing. And if we don't evaluate auditory processing, we really haven't evaluated hearing. The average audiologist focuses on the ear, not the brain, and the average audiologist is quite content to evaluate hearing sensitivity and perhaps word recognition. But those are both very simple tasks. They're not really going to provide much information about how a person can actually communicate. And I'll re-emphasize that the traditional simple quote-unquote hearing test, which is often simply pure tone air conduction audiometry, bone conduction pure tone audiometry, and maybe a word threshold test, a speech reception test, and word recognition test, those do not evaluate hearing. And many patients who have perfectly normal hearing test results using that simple test battery will actually have hearing loss or hearing problems that are not being diagnosed or even identified. So if you run into an audiologist who says, you know, I really never see these patients with auditory processing disorders. You know, I hear people talk about them, and you know, it sounds like there's a lot of them, but I don't think so. I just don't see them. Well, those audiologists are actually encountering those patients and not even recognizing them. This is a very common problem in audiology. If you are seeing an adult population, and that adult population includes elderly adults, and I used to refer to elderly adult as 65 and older, but I think it must be much older than that now, because that doesn't seem very old since I'm past that point. But there are older adults who have normal hearing sensitivity, and yet they have auditory complaints, and their loved ones, their children and family complain about their hearing. And then there are other older adults who have a hearing loss and who are being managed appropriately for that hearing loss with a hearing aid, and yet they don't do so well. They come back to the audiologist saying, this hearing aid's giving me a little help, but not much. And then they'll go on to describe, again, the problems they're having. Well, those two groups of adults, whether they're just older adults, or maybe they've had a head injury, or they've had some neurological insult, that may be some kind of neurological disease, or perhaps even some evidence of cognitive decline. All of those adults are at risk for auditory processing disorders. In fact, I would say the odds are they have them, and it's our responsibility to evaluate their auditory processing. Now, another group of children that audiologists encounter, maybe without realizing it, who have auditory processing disorders are children. And if you're an audiologist seeing children in the clinic, if you see 100 children who come into the clinic with complaints about their hearing, or their parents or teachers are complaining about their hearing, you can be sure that a sizable proportion of those children have auditory processing disorders. And if you have a child who seems to have a hearing loss by all complaints and symptoms, and yet when you perform the audiogram it's normal, that child is at great risk for auditory processing disorder. You can almost be certain that there's some evidence of auditory processing disorder that is explaining their auditory complaints. Now, evaluating children and adults for auditory processing disorders is not a difficult task, and it doesn't take too long. In fact, in an hour to an hour and 15 minutes, I can easily evaluate peripheral auditory function and at least screen patients for auditory processing disorders. Now, you don't need to do that with every patient, but if we use risk factors, we can identify which patients are most likely to have auditory processing disorders, and we can focus our attention on them when it comes to further evaluation. So as I've said, in my opinion, and really if you look at the scope of audiologic practice in the USA or in the UK or in really any other country, I would say that the identification of auditory processing disorders is the responsibility of any audiologist. And I could go into the medical legal ramifications or consequences of not assuming this responsibility as an audiologist. Now, we don't practice audiology in a certain way to prevent professional liability, to prevent lawsuits. But if we look at the scope of audiologic practice from the perspective of the legal profession, that is, are we doing what we should be doing as audiologists, and are we not doing things that we shouldn't be doing as audiologists? That's kind of a simple definition of the scope of practice. Then clearly audiologists should be identifying, diagnosing, and managing auditory processing disorders. Nobody else is around to do it. We're the experts to do that. It's like any other problem that any health professional deals with. Either you identify it and manage it, diagnose it and manage it, or you refer the patient to somebody who can. It's simply inappropriate. It is inadequate for an audiologist to ignore the possibility of auditory processing disorders in a patient and to simply let a patient go from the clinic with the blessing that they have normal hearing, when the only hearing test that's been done is a pure tone audiogram, or perhaps pure tone audiogram with simple word recognition. That is not practicing standard of care, and that is not fulfilling our responsibility as an audiologist. So now, in the ideal world, every student who is in a graduate program or any program leading to a degree in audiology, every student would be thoroughly introduced to auditory processing disorders, would understand how to evaluate them and how to manage them. But that's unfortunately not reality. And so these workshops, such as this one on auditory processing disorder, I think can bring audiologists up to speed and get them to the point where they're now functioning adequately within their scope of practice, and they're providing standard of care to every patient, including patients with auditory processing disorders. If you don't do that, I'm going to give you two scenarios real quickly, and these are not hypothetical. Each of these scenarios that I'm about to outline, and I'll get into this more in detail in the workshop, but each of these scenarios I have encountered as a medical expert or expert witness in the legal system. In other words, some lawyer has contacted me asking me to provide an opinion on the standard of care provided by an audiologist or multiple audiologists having to do with auditory processing. So here's the two scenarios. One is a child who's right away as they enter school, they're 5 or 6 years old, they are experiencing trouble. They're underachieving academically. They might be failing. And by the time they get to be 8 or 9 years old, when their classmates are learning to read and using reading to learn, our poor patient is not learning to read and is getting very discouraged. They don't want to go to school. They wake up in the morning with a sore stomach, and they're sometimes vomiting. They're just so upset they don't want to go to school because they fail constantly. And that child goes through this process year after year, and now they're 13 to 14 years old. They're still doing very poorly in school. Now the psychologist says, well, we don't understand really what's going on here. They have normal intelligence. They've had an IQ test. It's normal. And the speech pathologist says, I can't figure it out. This child's doesn't really have a language problem, and yet they're failing in school. They've got a supportive family. In fact, the family is so upset about this that they've decided to find an expert to evaluate this child. And I happen to be the expert who one set of parents found for a 14-year-old child who was so discouraged he was under the care of a psychiatrist. He really was tired of dealing with this disappointment and stress and frustration day after day after day. In a matter of an hour and a half, I performed an audiologic assessment which clearly showed that he had an auditory processing disorder. It was a rather unique pattern, but very clear. And in fact, the parents' mother ended up taking him to a radiology clinic at a major medical center, and functional MRI was performed on this patient. Functional MRI is like a moving picture of the brain activity as opposed to a traditional MRI, which is like a snapshot of the brain. So while this was my recommendation, while the patient, the child or adolescent, underwent different activities where he's listening to words and listening to sentences, his brain was being, his brain metabolism was being monitored, and he clearly had abnormal brain function in addition to the abnormal APD test results. Well, I ended up getting dragged into a courtroom to testify in this case, and it turns out that the first problems that this child had were back when he was in kindergarten and first grade, and he was never, ever sent for a full assessment of auditory processing disorder. Now, there was a major legal case there to be made against the school system and against every audiologist who had seen this child in the clinic and said, oh, you don't have to worry, your child has normal hearing, because this guy did have a normal audiogram. So there's an example of a very serious misdiagnosis or lack of diagnosis of an auditory processing disorder in a young child, which led to serious problems. And I've had many cases like that, not medical legal cases, but other cases which were so sad because these children could have been detected early, diagnosed accurately, and managed very, very effectively. I've also seen adults. I've seen many adults with auditory processing disorders. And some of these adults had head injuries, which could explain the auditory processing disorder, but others had probably an auditory processing disorder from childhood. But they were bright, very bright. Many of them went on to college. I've had a couple of patients who are lawyers, physicians, very intelligent people. And then as time went on and they got into their 50s and 60s, their peripheral hearing began to decrease. Sometimes it was age-related. For one of the patients, he had a cholesteatoma on both sides. And with the loss of peripheral auditory function, that is, with the loss of auditory input, these patients started to encounter problems because their auditory processing was already poor. But with their brain power and with a really good input with normal hearing, they'd done well, but now they didn't have that input. They were missing a lot of information, auditory information, because of the hearing loss, and their auditory processing skills were inadequate to deal with that reduction in input. Well, with a patient like that, if they go to the typical audiologist who tests their hearing sensitivity, they may well be told, well, you have a mild hearing loss, these hearing aids should help you. But they didn't help. And now we've got problems of people getting fired from their jobs, people refusing to socialize anymore. They don't want to go to restaurants. They don't want to go to places where other people are talking because they can't understand what they're saying. We run into the psychosocial problems that we encounter with children: frustration, irritation, discouragement, even pure depression. And this is all totally unnecessary. Any audiologist could have identified those people, adults or children, with auditory processing disorders. They could have performed a simple test battery, which I will describe in the workshop. They could have confirmed that there was an auditory processing disorder, and then they could have taken steps to manage it. And here's the really good news. Unlike peripheral hearing problems, say a sensory hearing loss, which is permanent very often, rarely is it reversible, auditory processing disorders can be reversible. The brain can change. This is called neuroplasticity. And with the right intervention, it's amazing how quickly auditory processing skills can improve. And I have numerous cases. I've documented some of these cases in published publications, peer-reviewed articles, that with the right intervention, a year later, you can't identify any evidence of an auditory processing disorder. The brain has essentially been improved, brain function. You've really, truly remediated their problem. So I guess I've made my point that all audiologists should be involved in at the very least, keeping their radar active for the possibility of auditory processing disorders in every patient, with the specific focus on those at risk for auditory processing disorders. And then some of you, I really hope that some of the people attending this workshop, some of you, will at the end of it all say, you know, I'm going to carve this out as one of my areas of expertise. This is a population that deserves my attention. And not only will you help the patients, you'll help yourself, because word will get out. Word will get out among audiologists, but also among the public. Word will get out among physicians, otolaryngologists, particularly for adults, and pediatricians for children, and you'll start seeing lots of patients with auditory processing disorders, and that will hopefully help you professionally. Now here's a point that I've already hinted at, but I'll just come right out and say it. We hear with our brain. If you ask an average audiologist, what are you evaluating when you evaluate hearing, they'll always focus on the ear. But starting way back in the 1950s, and I was not an audiologist in the 50s, but I was alive, back in those years, Michaelbus, this guy, Helmer Michaelbus that I talked about, was one of the first people to say, we don't just use our ears for hearing. And most of the important aspects of hearing occur in the brain. Now, if you just stop to think about that for a moment, you'll see that this makes perfect sense. We all have encountered patients, any audiologist has encountered a patient who had a profound hearing loss, and whether they're an adult with an acquired hearing loss or a child with a hearing loss from birth, these patients with a cochlear implant and with some rehabilitation develop very effective communication. So they don't have hearing, but by substituting some auditory input through the cochlear implant, these people can begin to hear again and to communicate effectively. So that's kind of the simplest illustration that we hear with our brain, not with our ear. Our ears normally does help, but we don't have to have an ear to hear. We do need a brain to hear. And what we're doing when we evaluate hearing, in the true sense of the word, is to evaluate auditory processing somewhere in the brain, from the brain stem right up through the auditory cortices. Now, when we get to the workshop, I, of course, get into the definition of APD in more detail. Obviously, you can't evaluate auditory processing disorders unless you know what it is or what they are. And as my mentor, James Jerger, has stated, he has a great way with words. He very often can take a complex topic and distill it in just a simple phrase. And as he's pointed out, auditory processing means different things to different people. So I'm going to focus on the definition of auditory processing from an audiological point of view. And the first definition that you see here, at the one at the top, actually came out of a conference, a very interesting conference that I attended back in the year 2000. It's hard to imagine it was 17 years ago. It was a conference right around April or so, April or May of 2000. And Dr. Jerger convened the conference. He organized it. But it started out with a group of so-called experts on auditory processing disorder that gathered and developed a statement about auditory processing disorders that included a definition and then a recommendation for how they should be identified, diagnosed. We didn't get into the management at that conference. And that document, or that conference, was actually summarized in an article that appeared in the fall of that year, 2000, which was written by James Jerger and Frank Music. You probably all recognize the name Frank Music. He's a very big name in auditory processing disorders. I could certainly make that article available to anybody who was interested. Now, it's obviously a little dated, but it's really timeless. And one of the outcomes of that meeting was a definition of APD that I still rely on to this day. Auditory processing disorders, or disorder, is broadly defined as a deficit in the processing of information that's specific to the auditory modality. Now, at first, that definition sounds so simple to be almost useless, but in fact, it's a very concise yet all-inclusive definition, and I find it very, very useful. And I notice the first thing you don't see in that definition is a little letter C. They're not referring to CAPD, central auditory processing disorders. They're referring to APD. Auditory processing occurs everywhere in the auditory system. It occurs in the cochlea, it occurs in the auditory nerve, and all up through the brainstem and up to the highest levels of the auditory cortex. So it's really misleading, and it's really kind of a false dichotomy to separate central auditory processing from hearing. It's all hearing. And so this first part of the definition, auditory processing disorder, not central, is critical. We need to evaluate auditory processing throughout the auditory system. And of course, some patients, particularly the elderly with an age-related hearing loss, or perhaps a child with otitis media and auditory processing deficits, may have multiple sites for the dysfunction. And so they may have, I've run into children who have abnormal middle ear function, abnormal cochlear function, but they also have central auditory processing disorder. And obviously, that child's going to struggle much more than a child with any one of those problems all by itself. And the same is true, of course, for elderly. In fact, with the elderly, it's not uncommon to encounter a person who has a age-related high-frequency sensory hearing loss, a auditory processing disorder that is based in the central nervous system, and then also two other problems that may interfere with communication. Poor vision, so they're not able to use visual cues in communication, and some cognitive decline. So auditory processing disorders can occur anywhere in the auditory system, and they can also coexist with other problems. But here's another important part of this definition, very important, specific to the auditory modality. Now, we're not saying that the problems we're identifying are only auditory, but they have to be auditory, at least in part. So let's take the older adult. We're saying that with our test battery, we can identify that the problem is in the auditory system. We're convinced that it's an auditory problem, but there also may be other aspects to it, maybe cognitive aspects, maybe peripheral hearing loss, perhaps even an attention problem. And the same is true for pediatric patients. We've got to verify that the problem we're identifying is an auditory problem. And just because you're using auditory tests in a test battery doesn't mean the results are going to lead to confirmation of an auditory problem. So you can have a patient with a very severe attention deficit who will have poor performance on auditory tests when in fact the auditory system's normal. You can certainly have children or adults with cognitive deficits who do very poorly on our auditory test, but they don't have an auditory problem. And we could include some other explanations for poor performance on auditory tests in patients who really don't have an auditory problem. Language is a good one. You're using English language tests, but they're a native speaker of some other language. So I've spent a lot of time talking about this definition, but I think it's very important. Number one, we're looking for problems throughout the auditory system. And number two, they have to be specific to the auditory modality. Again, the patient may have other problems as well. Another definition, or part of a definition, a characteristic of APD, is listed with a second bullet point, and this is from a kind of a technical report that was produced by the American Speech and Language Association, Hearing Association, back in 2005. And it has to do with the efficiency and the effectiveness by which the central nervous system utilizes auditory information. And this is very important. We won't dwell on it now, but I'll cover this more in the workshop. You will encounter many patients who can, under ideal circumstances, someone speaking very clearly, without an accent, in a perfectly quiet place, maybe with some visual cues, they can communicate quite effectively. But with someone speaking rapidly, perhaps with an accent in a noisy setting, they're not able to efficiently process that information. They're not able to function adequately. And so not only is the test score on an auditory processing test important, but there's also some valuable information on how easily and how effortlessly the patient produced that test score. And very often we may just get a glimpse, just a tiny little glimpse at the difficulty a person has during our auditory testing for an hour or two in a very controlled environment, and yet that patient will be struggling mightily throughout the day in communicating because they're very inefficient and their communication is not very effective. And the final point I'll make here, and we'll go into this more in the workshop, is that APD can be seen in a variety of different types of patients, children and adults, sometimes in people with clear damage or dysfunction in the nervous system, degenerative diseases, for example, or head injuries. And then it can also, auditory processing disorders can also arise from disruption in the neurobiological development of children. In other words, the complex auditory regions of the central nervous system just didn't develop as well as they should have. And in that respect, the auditory processing disorder is much like a child with a specific language impairment. There's no obvious etiology for their problem, and yet they have it. Now, in the case of APD, very often, there are some indicators of a neurobiological problem in developing within the auditory system, such as chronic otitis media, and long periods of time when the brain was being formed in childhood when the child was not hearing normally or consistently. All right, now I'm still kind of laying the groundwork here for the importance of all of you to increase your knowledge of auditory processing. And when it comes to children, of course, obviously this is an audiology viewpoint, not a speech pathology or psychology viewpoint, but there's plenty of research confirming that auditory processing, the very basic processing of auditory information, is a foundation for later communication skills. It's important to keep in mind that every child, before they learn to read, so every child up through age 8 or 9, every child up through grade 2 or 3 at least in school, is acquiring almost all of the information they get through the auditory modality. Now, if they're watching television, some of what they're getting is through the visual modality. I'm not saying that that's not important, but most of the information that leads to the development of language, both written language and oral language, is totally dependent on the integrity of auditory processing. So auditory processing deficits are strongly correlated with some children, with reading problems and with language impairment. And then in other children, there are coexisting deficits in both language and auditory processing. And certainly there are some children with only auditory processing problems that don't affect language, and other children with language problems that aren't they don't have any auditory processing deficits. But this is a very common pattern. We see a child with auditory processing deficits. They're sent off to the speech-language pathologist, and that professional documents a language impairment. And then we ask about their reading, and it's very, very poor. And we find that formal evaluation of phonological awareness, the ability to hear and distinguish and manipulate phonemes, speech sounds, oral, auditory speech sounds, is very, very poor. And without phonological awareness skills, language and particularly reading will usually be involved. Now, if you had to find, if you wanted to, here's a little, not a trick, but a little suggestion. You're walking into a elementary school classroom, and let's say there's 25 children in the classroom. Let's say it's first grade. And here's your task. You are told you have 2 minutes. 2 minutes to identify the children in that classroom who might very well have auditory processing disorders. You're supposed to find those children quickly so that you can evaluate auditory processing. 2 minutes, well, boy, that's going to be impossible to perform any formal screening or even a paper pencil inventory. Here's the question I would ask of the teacher. And you'll have no problem getting an answer for this question in 2 minutes. Identify for me the children in your classroom who experience difficulty, who perform poorly on spelling tests when you say the word and they're supposed to write the word that you're saying on a piece of paper. Or when you say the word and they're supposed to spell the word back to you. So if you say the word scat, S-C-A-T, they're supposed to say S-C-A-T. Just show me those children who struggle with that. You've already given them spelling tests. They're in the first grade, second grade. So most teachers would say, well, these 3 or 4 children are struggling with that skill. Those are the children most likely to have auditory processing disorders, because it's a pure auditory processing and phonological awareness task. Now, obviously, we'll talk in the workshop about how to screen for auditory processing disorders. And of course, if you screen all children, you'll pick up the kids with APD, or you can focus on the kids at risk for auditory processing disorders, and you pick up most of them. So this is another important point. We're not just talking about auditory processing, and we're not just talking about hearing. We're talking about a building block for communication and a cornerstone for language and literacy. The bottom line is, if you don't do well with reading, you're not going to do well in school. And if you don't do well with reading and you don't do well in school, you're going to struggle in life. And that's becoming even more and more true with every passing year, because information and communication is taking on more and more importance in this complex world we live in. Okay, so what if we wait around until children with auditory processing disorder are finally discovered because of the problems they're running into, rather than trying to identify them at the earliest possible age? Well, the children, by the time we find them, will have ineffective and inefficient communication, which will lead to a bunch of other problems. They will probably be poor readers or non-readers. And I should say that in a typical school population, particularly in a lower socioeconomic group, in the United States we have what's called Title I schools. Title I schools, it refers to a law passed in Congress many years ago. Title I schools are schools where basically you have a lot of children coming out of impoverished, poor environments. And the definition for Title I school is 80% or more of the children in that, these are elementary schools typically, 80 or more percent of the young children need to have a free breakfast and a free lunch at the school. In other words, there's not enough food for them to eat at home. Their parents are that poor, if they have parents, and so they are given free lunch or free breakfast at school. And that's a Title I school, if 80% or more of the children meet that criteria. Well, that's where you're going to find a large number of kids, at least 10%, who never really learn to read. 10%, just think of that. If there are 1,000 children in the school, that means there's at least 100 kids who are just never going to learn to read. Now, that doesn't mean the other 90% are good readers. It just means that that 10% are simply not going to learn to read. And they're going to just never make any progress. With every year, they're still reading at the kindergarten or first grade level. If you look at that 10%, and I will talk about this in the workshop, you will find that virtually every last one of those children has an auditory processing disorder. So the consequence of late identification of APD is not just inefficient communication, that's bad enough, or reading delay or failure. It's very often children who drop out of school, children who end up getting in trouble. And if you go to the prisons or you go to places like juvenile detention centers, you'll find they're populated with a lot of kids with auditory processing disorders. Because academic underachievement or failure is not uncommon for children with APD. Now, another consequence of late identification of APD is later language impairment. Now, not all children with APD will develop language impairment, and as I've already mentioned, not all children with language impairment will have APD, but there's a strong relationship. And then we have the psychosocial problems, and I will talk about this in the workshop. And I'll give you some articles that I'm an author on, that I've had students and over the years who focused on this aspect of APD. Kids with auditory processing disorders have unusually large number of psychosocial problems. In fact, our research shows that a sizable proportion of children with unidentified APD, that is, nobody knows they have it and they haven't done anything about it. Once we find them with APD, they have psychosocial problems that are at the level where a psychologist, a child psychologist would say, my gosh, this kid needs therapy. But here's the good news. We also found that with effective remediation of auditory processing disorders, the psychosocial problems go away. So they're not children who are depressed by nature or having problems interacting with others and interpersonal problems by nature who then have APD. It's the APD that leads to the psychosocial problems. And we even found that children with language impairment don't have the same kind of psychosocial problems. So from my point of view, if for no other reason, this is a good reason for audiologists to identify children with APD. Why should a child go around suffering with psychosocial problems? And we'll list them at the workshop. But, irritability, frustration, anger, being very discouraged, being even depressed. Why should a child put up with all that when in fact all of it could be eliminated if we address the APD? And I've already made the point that children with APD are much more likely to end up in special education or to drop out of school. And the longer we wait to identify the children, the longer it takes to remediate their problem if we are able to do it effectively. So if we identify a child in kindergarten with an auditory processing disorder, that child usually can be helped with management very quickly. Whereas the 13 or 14-year-old child, or even the 10 or 11-year-old child, it's going to be much more difficult. We may never completely remediate the APD. Okay, I don't want to, I'm keeping an eye on the clock here, and we're about 45 minutes into this. I don't want to dwell too much on the background information, but I'll say that the consequences of auditory processing problems are not just limited to children. They also can be very serious in adults. Obviously, we can also have ineffective and inefficient communication in adults. And here, the consequences are somewhat different than in children. And we're assuming that the adults, for the most part, have communicated effectively in childhood until they were identified with APD. Well, here we're talking about difficulties with employment, with keeping a job or even getting a job. In the United States, we have most states in the United States have a department or a part of department, usually Department of Labor or some other department, called vocational rehabilitation. Vocational rehabilitation. So this is where you've got somebody who really doesn't have a job, at least not a good job where they can actually make a living. And so they're sent to a counselor, and counselor directs them to special training and education to get them ready to take on a job. And it doesn't have, we're not talking about college education. It could be a job as a plumber or as a doing simple business, helping in a business of some type. It may be working in a printing factory. It could be anything. And if you go to the population of young adults who are in vocational rehab, you'll find a lot of people with APD. I've looked at that. And I've had patients just come to me from vocational rehab. So one consequence of APD in adults is underemployment or unemployment. Just like, you know, if you have a patient with serious peripheral hearing loss, one of the problems is they're going to be underemployed or unemployed, and their earnings are always going to be less. There's great research showing that hearing loss in adults that's not treated, now we're talking peripheral hearing loss, that's not being treated or managed with a hearing aid, they make a lot less than adults who are hearing normally. And the same is true for APD. Another consequence of problem with of APD in adults is that it's not recognized. An audiologist doesn't evaluate them, and so the assumption is it must be a cognitive deficit. And so you have adults who are being classified as having dementia when in fact they have auditory processing disorder, or maybe they have both, and they're experiencing the consequences of both poor cognitive function plus auditory processing disorders. When we get to the workshop, I'll talk about this. In fact, it's very interesting to perform a series of APD tests in a group of patients who are supposed to have cognitive deficits, such as a group of patients with Alzheimer's disease. And you'll find some of these patients actually don't have much Alzheimer's disease, but they have a lot of auditory processing disorders. Now, most auditory processing tests do require some cognition to perform the test, but we're talking about a person who's being identified with a cognitive problem, which is in fact auditory. What's the consequence of that? Well, heck, if we as audiologists had identified the APD in that patient, diagnosed it, and properly managed them, they wouldn't even be in this category of possibly having cognitive deficits. They'd be functioning adequately. So we really always need to consider auditory processing disorder in anyone who's been diagnosed with cognitive decline. And some of those patients actually will have a pure auditory problem. Anytime you have a deterioration in cognitive function, it's the same brain, of course, that is involved in auditory processing. So decline in cognitive functioning often goes hand in hand with a decline in auditory performance. And as audiologists, we're not going to do anything directly with their cognitive function, but we certainly can improve their auditory processing, and we can improve their hearing through hearing aids and other devices. And research shows that the more we can help a patient with auditory function, the slower the cognitive decline. We've already talked about psychosocial problems in children, and they're not limited to children. They also can occur in adults. So adults with auditory processing disorders, with or without a peripheral hearing loss, will begin to withdraw. They'll not socialize. They'll be less likely to be involved in the activities that they really enjoy, and going to church, going to restaurants, visiting with friends, traveling, and consequently, they end up becoming quite discouraged. Quality of life deteriorates. And I've already mentioned the problems with employment. If you have an adult with APD, I can guarantee you that properly addressing the APD will always have a beneficial effect on their work. Either they'll work with less effort and less stress, or they might actually even begin to get promotions or a better job. And we've already talked about quality of life. That's what it comes down to, both for both children and adults. We're not just talking about hearing. We're not talking just about auditory processing here. We're talking about you and I as audiologists improving a person's quality of life. And that can be invaluable for a patient and for their family. All right, I've already hinted that when we're evaluating auditory processing disorders, the patient may have other problems as well. Now, there are some in audiology and some outside of audiology who would say, well, we need to always evaluate all of these other problems first before we evaluate auditory processing. In other words, if a child comes to you for auditory processing assessment, you should first make sure that they've had a language evaluation and perhaps a cognitive assessment, and that they don't have a peripheral hearing loss. I don't agree with that approach. If we were to insist that every patient we see first have everything else evaluated, we'd see very few patients. It's not feasible. Not feasible for the parents if it's a child. It's not feasible for an adult. So we can plug into the process at any point. We may see the patient because they're referred to us by a speech pathologist or by a neurologist or a psychologist, but we may see the patient first. And then our job is to verify whether or not that patient has an auditory specific disorder, and then to make the proper referrals. So it's helpful to have some of this other information, but we don't need it to evaluate the patient. Ultimately, if we have any concerns about any of these problems on the list, we need to make the proper referral to a professional who can actually evaluate those. Now, this whole area or issue of coexisting disorders, problems occurring in the same patient with APD, add to the challenge of evaluating auditory processing disorders. In fact, some audiologists will say, this is why I don't evaluate APD. It's too confusing. I don't know how to sort out all these problems. Well, I'm going to point out that even if you're focusing strictly on performing audiograms, which I don't think you should, but if you do, and simple measures of peripheral hearing function, you're still going to have to deal with this. You're still going to have to deal with language where you're explaining the test to the patient, and you're still going to need to deal with attention, focusing an adequate amount of sustained attention during the test to get adequate results. You're still going to have to deal with developmental delay in interpreting results, particularly in children, relative to the child's developmental age. Determining even which test to use in a 5-year-old who's really developmentally at the age of 2 or 3, it's challenging. You've got to essentially test them as if they were a 2 to 3-year-old. And if they have autism spectrum disorder, that's going to be a challenge as well, because you may not even be able to get the earphones on them. They may be tactilely very defensive, or they may be so bothered by loud sounds they can't even tolerate the probe tone for emittance measurements. So the challenges we have in evaluating auditory processing that are brought about by these coexisting disorders are not unique. We deal with them as well for peripheral assessment. Now, how do we know which patients are most likely to have auditory processing disorder? I mean, we won't know for sure until we evaluate them, but we can evaluate every person in the world. And that would be a poor use of our time. Most people don't have auditory processing disorders. So how can we sort out who is most at risk? Well, it's not that difficult. In fact, after the workshop, you could go back to your clinic, whether you're working in the National Health Service or you're working privately or wherever you might be. You could put together a history or revise your history to identify most adults who might have APD. I mean, just on paper pencil test. So we've already talked about some of the etiologies associated with auditory processing deficits. Traumatic brain injury is a good one. Cognitive decline, any neurological disease or disorder, stroke, etc. Any patient with a medical history revealing one or more of those etiologies automatically suspect they might have APD. I would say you're not doing your job as an audiologist unless you evaluate or at least screen for auditory processing disorders in those patients. And then go by the audiological history. They've got an audiogram in front of them, or you have one for them in front of you. Is their communication consistent with that audiogram, or are they having more difficulties than you would expect for that audiogram? If the answer is yes, their communication complaints are greater than I would expect based on that mild high-frequency hearing loss, they are at risk for APD. What if their audiogram hasn't changed over the years, showing the same thresholds, and yet they keep having more serious complaints? And their family members say, you know, grandma's hearing's getting worse and worse, and you're looking at the same audiogram over the course of 3 or 4 years, suspect auditory processing disorders. All of this is evidence-based, by the way. There are cases in the literature documenting each of these risk factors. Or you have a patient, you're an adult, you're an audiologist who provides services to adult patients, mostly fitting them with hearing aids. Most of your patients do quite well. You're actually, you take great pride in properly educating your patients, counseling them, fitting them with the most appropriate amplification, and usually get good results. But now you've got a patient where you did everything you always do and they're not getting much benefit at all. Immediately suspect auditory processing disorder in that adult. Audiological findings. That is, what audiological findings would make you really be concerned about auditory processing disorder in an adult? Well, if they have normal ipsilateral reflexes and their contralateral or cross reflexes are absent or grossly elevated compared to the ipsilateral, suspect auditory processing disorders. Very poor word recognition, particularly in the presence of not that great a hearing loss on the audiogram. Rollover on word recognition. So at the highest intensity levels, their scores on word recognition are poorer than at lower levels. Or, and this is a very common problem, problems with speech and noise. So if the audiological history, if a patient says, I'll tell you where I have the real problem. I can hear you just fine in this quiet room, but I struggle in a restaurant, I struggle in a crowd, I struggle when I'm on the bus or on the train, you automatically should evaluate speech and noise, speech perception and noise. And there are obviously many tests available to do that. Sometimes you'll find that the patient seems to be adequate in terms of their scores on tests, but it takes them so long to produce the responses. You're constantly slowing down the test and having to give them time. And they're telling you, boy, this is tiring me out. Then that also is a risk factor. And as I said, poor benefit from amplification is always, in an adult, a risk factor for APD. Now, I meant to include risk factors in children. I don't know where that slide went. We'll talk more about it at the workshop. But let me just point out that in children, some of the key risk factors are a stay as an infant in the neurointensive care unit. The neonatal intensive care unit, the intensive care nursery. If a child has had asphyxia or some serious health problem that requires some time in the intensive neonatal nursery, then that's a risk factor. Any child with chronic otitis media throughout the preschool years, any child with language delay, any child who's struggling, now we're talking about school age, struggling in the classroom and there's no obvious explanation, all of those children are at risk for auditory processing disorders. Okay, now we're at 2:30 and I'm going to wrap up within the next 20 minutes or so, and by just quickly reviewing how the workshop will be, the structure of it, or the agenda, and what we're going to cover in the workshop, how we're going to run the workshop. The first point I want to make is that I'm not the only speaker. Harvey Dillon from Sydney, Australia, will also be an instructor. Now I'll be on site in flesh and blood right there in Greenwich, and Harvey Dillon will be still in Sydney, Australia, and he will be giving virtual lectures, kind of like what we're doing right now, I presume. I've known Harvey over the years. Our interests for many years were not real similar. In other words, I'm more diagnostic, really into auditory processing disorders, tinnitus, hyperacusis, diagnosis of hearing loss in infants and young children. Harvey, for many years, was a big name in hearing aids. But as time has gone on, he has done more and more research in auditory processing and developed or helped to develop some auditory processing tests and treatment strategies. And I've visited the National Acoustic Laboratory in Sydney and got a tour from Harvey of the facility, which is quite impressive, and we've always hit it off. We've had some interesting experiences over the years where we've both been at a convention or a meeting like the American Academy of Audiology meeting, and people have come up to each of us individually. So they've come up to me when I'm by myself or him when he's by himself, and they've mistakenly identified one of us as the other person. So somebody came up to me and said, well, I really enjoyed visiting with you at that meeting in Greece, or that cruise that you took. And I'm thinking, gosh, my memory is really starting to fade. I don't even remember even being on that cruise. In fact, I've never been on a cruise. And then I find out that in fact they were talking about Harvey Dillon. And the same has happened to him. People have come up to him and they started asking questions and talking to him as if he were me, and he's been totally lost. So actually, when you get us both together, we don't look that similar, but for some reason, some people think we look alike. But we do think alike, certainly, and I think my perspective and Harvey's will make for a very, very practical and good workshop. Now, day one will consist of lecture sessions focusing on the identification of APD, and we'll talk a lot about history and risk factors. And if you take nothing from the workshop but that, now obviously I hope that you are there for both days and you attend and focus on what is going on throughout each day. But if you only go away knowing how to identify APD, I will feel like we've accomplished something, because then hopefully those patients coming into your clinic who might have APD will end up getting properly diagnosed and managed somewhere. The second main focus of the first day lectures will be on the assessment. So I'll put together a test battery for evaluating peripheral auditory function quickly and efficiently, and then I'll put together a test battery or help you construct one for assessing auditory processing at the brain level. And we will, at the second day, follow up on that kind of classroom learning with some hands-on sessions where you will have an opportunity to try your hand at constructing test batteries based on the patient's age and their chief complaints and what we know about them. And then we'll practice scoring some of the tests, which is not that difficult, but it helps to review it and to know what you're doing. And that way you can be much more efficient in the clinic. And then how to analyze the test results of it, both individual tests and the test battery. The second day will focus mostly on management, including the options for management, and there are options, and the management can be very effective. And some of them are implemented by audiologists, others are implemented by a team. In fact, we'll talk about the multidisciplinary team that you really need to put together to properly diagnose and manage APD. So the workshop will be a combination of face-to-face lectures, but that doesn't mean that Dr. Dillon and I are just going to be blabbing away while you sit there passively. We're going to have a group that's a perfect size for a lot of interaction and questions and answers. And you can ask me questions, I'll ask you questions, and it'll enhance the learning experience. And then the hands-on sessions are essential in any workshop to really make sure that the information can get implemented in your clinical practice once you get back to work after the workshop. So that's the structure. The content obviously, we've covered a lot of the material already. I've just kind of provided you with an overview this afternoon, or this evening for you. So we'll really get into the definition of APD, and I won't just use the slides that I've used. We're going to make reference to clinical practice guidelines and other documents which have developed definitions. Now, I'll be the first to admit there's no universally accepted single definition of APD. Even in a country like the United States or UK, there are different definitions of APD generated by different people. And certainly when you get outside of audiology, speech language pathology or psychology or medicine, then there are even other definitions of APD. But we'll come up with a general consensus of what the term means and how to define it. Then we'll talk a lot about risk factors. Again, that's so important for quick identification and consistent identification of APD. We'll talk much more about coexisting disorders in children and adults, and then we'll review all of the tests that could be used for evaluating peripheral or central function. Now, I'm not going to suggest you use all the tests. I'm a big proponent of what I call value-added tests. In other words, tests that contribute not only to the diagnosis, but to the management and the improvement of patient outcome. So bottom line is, if there's say 20 procedures that you could use to evaluate the patient, you need to systematically say which of these 20 procedures actually will provide useful information. And the ultimate question is, if I perform this procedure, will the patient's management plan be changed? Will the outcome of this procedure I'm considering, will it actually affect what I do with the patient? And will it affect how the patient does with my management? And if the answer is no, then don't do the test. So even though we have many, many procedures at our disposal, we select them carefully in a very well-designed, efficient test battery to evaluate peripheral auditory function and central auditory function. And very often, based on history and other test results, certain procedures just aren't appropriate for a patient. They're not necessary. So I approach the assessment of APD in a very practical, clinical way. I'm not coming at it from an academic perspective where I'm saying, well, it would be interesting to do these tests. You never know what you'll find. We want to have not a bare bones test battery, but we want to have a test battery where every procedure has been selected for a reason. And we're not performing extra procedures that we don't need to perform, but we're also using all the procedures we do need to perform. We're not going to exclude a test procedure that we really should use. Now, for the management of APD, obviously management's critical. I mean, I would argue if you spend a lot of time diagnosing APD, but then you don't do anything about it, you haven't provided a very valuable service. Now, there certainly is some value in identifying APD for a patient. And certainly if you have a child with APD, a patient who's a child, their parents will tell you, very often with tears in their eyes, thank you so much for finally telling me what my child's problem is. What a relief to know what's behind their failure in school, that they're not stupid, that they don't have autism, that their problem is recognized and it has a name. People know something about it. So I'm not saying that the diagnosis alone doesn't have value. It certainly does. But, and for medical legal reasons, very often if you confirm auditory processing disorder and somebody that's been fired from their job or gotten into trouble some other way, maybe that diagnosis alone will be their salvation. But most of the time, once we find out that they have an auditory processing disorder, we want to put together an individualized management plan to properly remediate or mitigate their auditory processing disorder's impact on quality of life. So we can do that through counseling. We're going to spend quite a bit of time talking about counseling in APD and empowering patients or parents of patients to be their advocate, to help them get what services they need, but we're also going to be their advocate. And we're going to talk about referrals. It's not uncommon, in fact it is very common, for us to refer our patients with APD to other professionals for their full management. And I'm a strong proponent of making all the referrals that need to be made right away, and not saying, well, let's do this for a while, let's try this strategy, and if it doesn't work, then we'll try something else. I'm going to want to get all the information on all the patients' coexisting disorders and develop a management strategy, or have someone develop a management strategy for each of those problems so we can get the best outcome as quickly as possible. We'll also talk about computer-based technology and techniques, which are a relatively new phenomenon, maybe the last 20 years, and which have been a godsend. Computer-based technology and techniques are so useful because they're relatively inexpensive to implement, and you can always find a computer to run these programs, whereas you can't always find certain kinds of professionals, like a speech pathologist with an expertise in phonological awareness. So we'll talk about, and there's always new technology and techniques being developed, and we'll try to sort out those that are evidence-based from those that are still too new for us to know whether or not there is evidence. Okay, so that's the content of the workshop. Very practical, very clinically oriented. Now, before the workshop, I have a few suggestions for readings that will help you get a lot more out of the workshop, and it won't take too much of your time beforehand. And then I'm going to, right after that, suggest some or recommend some other sources of information, resources on APD that it would be impossible to read ahead of time, but which you might want to refer to particularly if you take my recommendations to heart and you actually start implementing these APD services in your clinic, which I really hope you'll do. The first recommended readings that I'm going to refer you to are what are called clinical practice guidelines. And the AAA clinical practice guideline will be the first I'm going to suggest to you. Now, the American Academy of Audiology is now actively involved in producing clinical practice guidelines on everything audiologists do in the clinic. A lot of them have already been done, and in fact, several have gone through several revisions. The APD clinical guidelines, I'll show you the cover in a moment of the document, were finally went out for peer review in 2010, and then they were approved by the American Academy of Audiology Board of Directors. I was on the task force. Frank Music was the chair of the task force, and this was the very first clinical practice guidelines ever prepared for APD. Previous documents had all been kind of scientific, technical statements, but never really getting to the point of saying, here's how you should apply these clinically. So those guidelines are extensive. They're all evidence-based, and you can get at them very easily, but I'll show you an example. In fact, I can make sure to make them available to you all prior to the workshop. Along the same line is a British Society of Audiology position statement, which is produced around the same time, 2011. Actually, some of the people on that task force for the BSA statement were well aware of strong, close colleagues and well aware of the task force for the APD clinical guidelines and wanted to follow suit. Now, they're quite different. The guidelines are quite different, and the position statement is not quite as clinically focused as the practice guidelines, but still very useful. And obviously, these are your peers in the UK, assuming that's where you are. There are also a number of review articles, which I will provide the names for. Actually, I have the actual articles in many cases, covering everything from the neurobiology of APD to risk factors, to assessment, test batteries, sensitivity and specificity of actual tests, and then various treatment options and evidence in support of them. Now, there are numerous readings that you might go to, or resources you might go to after the workshop, and I can't see my picture here with the webcam, but I'll put this right in. If you're able to see me, hopefully you're able to see this book. This is the first volume of a 2-volume set by Frank Music and Gail Schermack. So the first volume covers the diagnosis, essentially, and background information, and the second volume, which is this one here, covers intervention management. And this book is very recent. This is the second edition, and I'm just looking at the publication date, and it's 2014. So this is very up to date, and it's Plural Publishing. So if you wanted to have a very comprehensive resource, this would be for somebody who's going to take APD assessment and management seriously. This 2-volume set would be what I would recommend. Now, you can get a lot of information inexpensively, though, from the internet with review articles. All right, over on the left-hand side of this slide, you see the cover of the AAA Clinical Practice Guidelines for the diagnosis, treatment, and management of children with auditory processing disorder. And then you see in the middle portion of the slide the cover page for the position statement of the BSA on APD, and then you can even further practice guidance is found on the left, and that's a more updated version of the guidelines for management of APD. So those 3 documents are what I recommend for your pre-workshop review. And I would say you probably read all 3 of them, at least just read them over, review them in a matter of 2 to 3 hours at the most. And then you'll be kind of up to speed for the workshop, and you'll get much more out of the workshop. I would also recommend, my suggestion for before the workshop, like right now up through when we start the workshop in May, is to think about your patient population. And you don't have to do much thinking. I mean, you know who your patients are. You could even do a little bit of research where you say, well, I've never really found out what the average age of my patient is, or the range, or what percentage of patients I see in every decade of life. And then think about how you might implement APD services in your clinical practice. That is, how much time do you have? How would the patients pay for it? Would there be reimbursement for some of the procedures? I've always found in assessing patients with APD that a lot of people say, oh, I don't do it because there's no money in it, we can't get any revenue, it's not good use of our time. And I disagree heartily with those statements. That if you put together the right test battery, and in the United States we have what are called CPT codes, current procedural terminology. So each procedure has a code, and you can get pre-approval to get reimbursed for a test battery of procedures with these codes. And in a typical evaluation, let's say a patient came with health insurance to our clinic, and we had prior approval in my 2-hour time frame, which I set aside for an APD assessment. I don't need all 2 hours for the actual testing. I'd leave at least a half an hour for counseling at the end and explaining the results. But I would send a bill out to the insurance company for about $600 to $700. And it was all pre-approved. These are legitimate tests. And the physician, we get a physician referral, pediatrician referral, to us saying, yeah, we want this information. This child's failing in school. They're struggling, and they probably have some type of auditory problem, but we don't know anything about it. We need this evaluation. And so depending on the collection rate for your facility, it was still a good use of your time. So from a pure financial point of view, from your perspective, it's well worth it. Obviously, it's invaluable
to properly assess and manage a patient for the patient themselves. So think about how you would implement, even before you come to the workshop, how you would implement APD services in your practice. What role do you want to take? And maybe you'll phase in. Maybe you'll start out by just trying to identify patients with APD. Maybe the next stage will be do some screening to kind of confirm your suspicions in certain patients, and then you'll refer those patients out. And then ultimately, maybe your goal is to provide services either to only children or only adults or both. So after the workshop, there are numerous review articles, the books that I mentioned, that you could consider. Okay, well, that is the end of my formal presentation. Hopefully everybody can still hear me, and I'm going to get rid of the PowerPoint. Okay, looks like Jay's still awake. Maybe he just woke up. But in any event, if you think we have a time for a few questions, I'm certainly open to that.
Absolutely. Thank you very much. That's very exciting. I am very excited to be there in May. And may I just say that you do have a very striking resemblance with Dr. Dillon. So well, I'm not blaming.
I don't know. Fortunately, he's not a ne'er-do-well or a criminal or something, a mass murderer. So if you're going to be taken for somebody, it might as well be a guy with a really good, or a guy that everybody thinks highly of. So
absolutely. All right. Now we do have time for some questions for those who can stay. If you raise your hand in the control panel, then I can turn your mics on. I don't want to turn all the mics on altogether, because that, by experience, I know will be a disaster. So if you raise your hand if you have any question, then I can turn your mic on and you can ask it live, or if you put it in the chat box, I can ask it for you. While people are thinking about it, can I just add that the new APD guidance, the newer update from BSA, has just been published today for consultation. So it's gone out for consultation. In my experience, being in that professional guidance group, it takes about a month or so before we get all the responses, and then it takes further 1 month or so for the guidance to be published after the comments have been received, unless the comments are so drastic that we have to change the guidance completely. So hopefully within a couple of months there will be the next update as well to APD guidance, and it is in public domain and everybody can have a look at that document if they like.
Excellent. So in the meantime, we will be going by the guidelines that came out in 2011, then I assume, or 13.
Sure.
Yeah. Okay.
Brilliant. I don't have any hands raised, so I'm just assuming that everybody's got what they wanted from the event.
Yes. If you want, the AAA guidelines are easily accessible to anyone, but I have a copy right on my computer. I'll send it to you, and that way, I don't know how you would distribute it to everybody, but that way they don't have to be searching around for them. I assume they can find the UK guidelines pretty simply, the BSA guidelines.
Absolutely. I can probably email everybody all the 3 guidance documents that you mentioned and the one that I mentioned, so everybody has an easy access to that. If it's too big for email, then I'll put it on Dropbox.
Okay.
And I send the links to everybody.
PDF files, so they're easily emailed. That shouldn't be a problem.
Sure. All right. Remain for me to thank you for your time, and I'm looking forward to see you in May.
Yeah, I'm looking forward to it myself. All right. Thank you very much, everybody.
Thank you, everybody who's attended. Thank you. Bye-bye for now. Thank you, Dr. Hall. Bye.
Thank you.